I'm Dr. Gary Ansel. I'm an interventional cardiologist from Columbus, Ohio, and as the Assistant Medical Chief for Vascular Services, I have responsibility for the budgets and the devices we're utilizing. I'm also on supply chain, so I get to see both sides of the issues. And this talk today is going to be getting new devices in your lab. What are the lessons learned? Well, the bottom line before we get started is it's all about value analysis. The big devil in the details is, but whose value and whose analysis? I can tell you from both being the system medical chief and sitting on the supply chain, there's a lot of great fibs that occur as people want new devices. It'll save money. It'll save time. It'll make things easier. If we don't do this, our competitors will, and we will use this all the time. The reality, most of the time, it doesn't save money. Oftentimes, it's more time due to complexity and a learning curve. Things oftentimes get harder due to training. The competitors will think like you, and they all have budgetary constraints. In reality, many of these things are outdated before you can measure a difference for any of these great promises. So why do we even have to think about that? Can't we have everything? Well, certainly if you look at where we're at in medical care and medical therapy, our inflationary prices are way beyond the typical norm. On the left, if you look at what things cost in 1942, like a car, gasoline, a house for $6,900, bread was 9 cents a loaf, a postage stamp was 3 cents, and you took the current inflation rate at what those kind of things would be if they went to the inflation rate of the medical devices. A dozen eggs would be $85, a pound of sugar $14, a roll of toilet paper at COVID, I'm not sure we want to hear this, $25, a pound of butter $108. So as you can see, the inflationary rate for medical devices and services has far outstripped the typical inflation of what we've been going through. And right now, when you're listening to this in the time of COVID-19, I can tell you economically, COVID-19 has affected the future of healthcare choices and its economy. But the reality is, we don't want to stagnate. It's all about patient care, credibility, and cost as you try to bring something into your lab, especially this day and age. You need to be credible. That means they need to be able to believe you. You need to be convincing. If you look at the bottom, you need to be able to discuss the same language as they do. You need to be able to see what's economically viable and non-economically viable. And there needs to be a trust in the relationship between the physician, supply chain, and the hospital that you're trying to provide the best care at the best price. To start off, you need to be actually very descriptive about, in the continuum of care, where does your new device fit in? Is it going to prevent something? Is it an advancement in diagnosis? Is it going to ultimately be a much bigger deal in treatment? Or is it even a different way of surveilling these patients with digital or some type of implantable pressure or whatever that might do that? You need to explain that to the team that's looking at your new device. You'll need to clearly state the fit for the institution, not only at the time of the procedure, but in the episode of care. And you'll need to clearly state the business plan of what you're actually trying to bring in. You as a physician that wants to bring in a new device need to be able to know the different variables that affect the price, not only from the cost of the listed price, but what are all the things that affect that cost of the institution. First, from a cost standpoint, are you going to purchase these or are they going to be on consignment? Are they going to require you to buy $70,000 worth of devices up front? Or are they going to say, hey, we're going to have trunk stock until you learn how to use these, and then we'll make this decision? One of the more expensive things that's out there that you don't really recognize are the shelf space. Shelf space is very expensive, as in any institution that has goods. So you have to figure out how you're going to do that. What are you going to take potentially off the shelf to make room for this? There's actually a cost for purchase orders as new things are brought in, so there is no free lunch. How are you going to track the usage? How are you going to really support those claims that you made? And then what about reordering? Are there going to be certain amounts of reordering? Who's going to do this? Are they going to be standard? How are you going to handle this down the road? Having worked on both sides of this issue, I can tell you there's some lessons for physicians as well as for industry. In this new day and age where we have to be much more economically efficient, new devices should typically replace old devices or techniques. You need to put that into your business plan so that it can be calculated. Safety or decreased length of stay should be assessed and evaluated by the user, and if not working out, you need to remove the new device. So in other words, if you make a promise and it doesn't come to fruition, the best way to maintain your credibility is to follow that and get it back off. Niche devices are not for everyone to absorb the price. Not every hospital needs to have the latest and greatest. It's just physically not reasonable, and it may not be allowable in the new institution environment we're in. Docs should push industry for comparative trials, not registries, i.e., if something says, I'm going to give you better luminal gain, it can't be from a registry. It has to be some comparison or less embolization. Well, let's prove it. Let's do a trial of 50 patients and see what that amount really looks like. That way we can actually feel more comfortable taking those other devices off the shelf. Again, the ideal situation is to take something off the shelf and it be replaced. So in summary, getting new devices in the interventional suite. First, partner with your institution. Act like it's your OBL or ASC. Act like you need to be fiscally responsible. Don't just continually add new to be new. Push on industry to provide real data so you have better arguments to go to administration and better upside for the patient. Help build the business case. Work with your administration to come up with the amount of financials, whether it be at the time of care or the episode of care in a year, to support bringing in that new device. But importantly, being on both sides of this fence, I have found that if you can replace another device or technique and take things off the shelf, it's a much better partnership and you'll be highly successful. Thank you very much.